Hello, my name is Tammy, and I'm going to start off on our presentation for ischemic stroke. We'll start a little bit with the pathophysiology. As you're all aware, a stroke occurs when a section of your brain doesn't get any blood. Some of the mechanisms by which that can occur is atherothrombotic occlusion of large arteries, cerebral embolism, proximal artery stenosis with hypotension, or normothrombotic occlusion of deep cerebral arteries, such as occurs in a vasospasm. And this is a picture of some of the cerebral arteries. So you see we have lots of opportunities to occlude some vessels. Okay. So we're going to start off with our patient, Mr. Smith. Mr. Smith is 58 years old. He was brought to the ER by his wife. She found him out in his garage around 8:30. He's having difficulty speaking, right-sided weakness, and some confusion. When she found him, he was sitting on the floor in his garage, and he was unsure of what had happened. The last time she's seen him normal was around 7. He is coming into the ER with abrasions on his knees and elbows, and his wife informs you that he's healthy, except that he has a history of high blood pressure, and he's had a heart stent about a year ago, and he did stop smoking after he had the stent. So this is his initial assessment. As you see, his blood pressure is a little high at 180/110. He's in sinus rhythm. His pupils are equal and reactive, and like we stated, he has the right-sided weakness, the right-sided facial droop. His lungs are clear. His respirations are even and labored at 20 a minute. O2 sat's fine at 97. He is alert and oriented to person and place, but he's unsure of what happened and why he's here. His speech is a little his speech is a little slurred, and he also has some expressive aphasia. And numbness, tingling, decreased sensation to the right side of his body. So the doctor comes in to see Mr. Smith, and these are some of his initial orders. He orders an NIHSS, CAT scan of the head. He ordered some lab work such as CBC, Chem12, PTINR, PTT, lipid profile, cardiac enzymes. He asked that Mr. Smith be kept in NPO until his bedside swallow screen is completed. He wants the nurses to begin the TPA screening form for this gentleman. He has a stat EKG and needs 2 IV lines, and we're going to go ahead and start normal saline at 100 on him once we get those going. We're going to weigh the patient, and we're going to continue to do neuro checks every 15 minutes on him, along with vitals for every 15 minutes.
Hi, my name is Ashley, and I'm going to be doing the phase 1. Stage 1 is his admission condition. So what's the most important thing to assess? One of the most important things to assess is his neurofunction. And he is alert and oriented and can follow commands. Next, we're going to assess his cranial nerves. And after that assessment, we decided that he has the right side facial droop. And his motor, he has right-sided weakness, and his speech, like Tammy said, is slurred, and he has expressive dysphagia. Okay, so his labs. His CBC, renal labs, and EKG are unremarkable. And the CT of the head, there was no bleeding, so that's a good thing, and it suggested of early ischemic changes in the left hemisphere. It is now 2 hours from onset, so the critical thinking question is, do you think TPA is an acceptable form of treatment? So, indications for TPA. Some of the indications is the patient needs to be at least 18 years old, which he is, and it needs to be given within 3 hours of the onset of the symptoms, and it's been 2. Contraindications would be intracranial hemorrhage, which we ruled out he does not have, active bleeding he does not have, and if his platelets are less than 100,000, he could not get this, and uncontrolled hypertension. So the answer to the question is yes, he's a candidate. So nursing interventions, we really need to be monitoring his blood pressure as ordered. The ACLS guidelines currently say monitor blood pressure every 15 minutes times 2 hours, then every 30 minutes for 6 hours, and then every hour for 16 hours. We need to be monitoring any cardiac changes and to continue to make sure the patient is NPO. Why? So the next critical thinking question, why should the patient continue to be NPO? Next, the patient should continue to be NPO because the patient is at severe risk of aspiration, and the swallowing should be assessed by speech therapy before he's allowed to eat or drink anything.
Hi everyone, I'm going to be doing stage 2. So this is after Mr. Smith had his TPA therapy. We want to do neuro checks every hour, monitor for any signs of bleeding after he's had TPA, and do vital signs every 2 hours, which is the most important thing is the blood pressure. So the physician orders labetalol 10 milligrams IV given over 1 to 2 minutes as needed for a systolic greater than 180. And we can repeat or double for every 10 to 20 minutes of a maximum dose of 300 milligrams. And the doctor also orders to check the glucose ACHS because people who have had a stroke have a high risk for hyperglycemic, whether they're diabetic or non-diabetic. The critical thinking question is why is it important to monitor blood pressure after patients receive TPA? So the first 24 hours after a TPA administration, they have a high risk of having a hemorrhage. So that's why it's really important to keep the blood pressure below 180 or 105. If a patient demonstrates signs of bleeding such as a headache, any neurological changes, or any other changes, it's important to obtain a stat CT scan, notify the doctor, and get some stat labs such as PTT, INR, your platelets, and call the code stroke. For the nursing interventions, we have to continue, like I said, checking the neural assessments because the patient could have a change anytime, and continue checking the vital signs every hour. So Mr. Smith is still alert and oriented. He still has his right upper and lower extremity weakness compared to his left side, and his speech is still slurred, and he still has some expressive dysphagia, and his pupils are equal round and reactive to light. So we also perform a bedside swallow screening as the nurse's job, and he fails his bedside swallow. So what's the next step after he does not pass his bedside swallow? So the nurse should notify the MD, and they should place him on a strict NPO diet until a speech therapist is consulted to able to see him. Like Ashley said, the patient is at risk for aspiration because of his slurred speech and dysphagia.
Hi, my name is Walinda, and I will be doing stage 3. The TPA was successful, and the blood clots were dissolved. And once Mr. Smith is stabilized, he is able to go into a stroke unit. Jacques and associates recommend that stroke patients be sent to a stroke unit because these are the multidisciplinary team that are experts. They know what to assess, they know what to monitor, and they can provide interventions that will ensure that the patient has optimum outcome. Some of the goals is to observe the changes that may require medical or surgical interventions, to observe treatment to reduce the risk of any kind of bleeding complications. They are to begin measures that will prevent subacute complications, monitor blood glucose, monitor his blood pressure, monitor his vital signs, facilitate medical surgical measures aimed at improving the outcome of the stroke, and to restore neurological function through rehabilitation. So this is his assessment. His blood pressure is 155/100. He does have a history of high blood pressure. Anti-hypertension medication would be provided, but you want to make sure that the blood pressure isn't so high that it will cause hemorrhage, but then you don't want it too low where it will impair cerebral function. His O2 sats are 94%, heart rate is 85, normal sinus rhythm, and the temperature is normal at 37 Celsius. You want to check to make sure he doesn't have a fever, because fever signifies infection. UTIs and pneumonia is common in stroke patients. He is alert and oriented ×4. His speech is slurred, and he has expressive aphasia. He has difficulty swallowing, and he has numbness and weakness in his right face and right extremities. Some of the nursing interventions is monitor the vital signs. You also want to put them on telemetry, because arrhythmias are common in stroke victims or stroke patients. One of the most common arrhythmias is AFib. Sustained nutrition and hydration. So he might have to be put on intravenous maintenance fluids or enteral feedings. Monitor for gag reflex and the ability to swallow. Reposition the patient every 2 hours to prevent bed sores, and do passive range of emotion exercises. Utilize the National Institute of Health Stroke Scale to assess his neurological function. You want to monitor for the bowel and bladder function. Place SCDs or tests to prevent blood clots. Assess for risk of falls, because he does have numbness and right side weakness in his extremities, and you want to provide patient education for them. Why is it important to sustain nutrition and dehydration? You want to sustain dehydration and nutrition to help with the recovery. Also, it is common for stroke patients to have blood clots because they are dehydrated. And dehydration may also cause hypotension, which can impair cerebral infusion. So why is it important to monitor for dysphagia? Because if he has problems swallowing, then food or fluids can go into the lungs, and this will cause aspiration pneumonia. Doctor's order for Mr. Smith, he will be getting heparin 40 milligrams. Sub-Q is recommended by Jacques and Anderson that that any anticoagulant is not given until after 24 hours or post TPA. He's to get SCDs and TEDs to prevent blood clots because he has limited mobility. His APTT will be monitored to make sure that his blood is correctly clotting. He will receive occupational therapy and physical therapy because he has the weakness and numbness in his extremities. He's also going to get speech therapy because he has difficulties swallowing. And early ambulation is recommended because, well, why is early ambulation important? It's because it can prevent DVTs, bed sores, pneumonia, joint disorders, and contractures. Thank you.